And today we are pleased to have a guest speaker with us. She's a friend already. You could see her jamming and dancing and doing the things that we were doing already. And we have the opportunity to hear from Betty, but there's just something before I introduce her. I was led to write and share with you that I'd like to share. And those are as follows. Hospice and palliative care play a critical role in the Black community, providing essential support and comfort and dignity to patients and families during serious illness or at the end of life. They are vital services that emphasize symptom management, pain relief, emotional and spiritual well-being, which can significantly improve the quality of life for patients, and hear this, their loved ones. Palliative care is particularly important as it is a holistic approach to patient care. It focuses on treating the person as a whole rather than just their disease. This is particularly crucial in the Black community, where socioeconomic factors can often contribute to health disparities. Palliative care can help address these disparities by ensuring that all aspects of a patient's well-being are considered and catered for. Furthermore, hospice and palliative care in the Black community can help combat, hear this, cultural stigma associated with serious illness and death. By providing culturally sensitive, By providing culturally sensitive care, they can foster open conversations about end-of-life choices, empowering patients and families to make informed decisions that align with their beliefs and values. However, despite immense benefits, Black communities are often underrepresented in hospice and palliative care. This can be due to lack of awareness, mistrust of the healthcare system, or cultural and religious beliefs. Therefore, it's imperative to increase outreach, education, and access to these services in the Black community to ensure that every individual has an opportunity to receive the compassionate care they deserve at the end of life. So finally, the role of hospice and palliative care in the Black community is of immense importance to us. It ensures that individuals facing serious illness or the end of life can receive high quality, holistic, and culturally sensitive care that respects their dignity and enhances their quality of life. Hence, I've heard from you all that this was a topic that you wanted to learn more about. So without further ado, let me introduce to you our esteemed guest presenter, Betty Samuel. Betty Samuel resides in Alexandria, Virginia. She is a seasoned marketing professional with a proven track record in achieving exceptional sales results. But guess what? More importantly, she's a friendly, customer-focused individual cultivating relationships with those that she meets on a day-to-day basis. She's very sensitive to the people that she serves. Betty's expertise is that she's for the last 16 years has been an instrumental person at the Capital Caring facility up at Capital Hospice. She has responsibilities including marketing, selling services for palliative care and hospice there. She has a very diverse customer base, so I think you will find that she knows what who she's speaking to tonight. She is dedicated to enhancing community awareness and eradicating, she said it too, the stigma and promoting early access to advanced illness care. Betty, welcome to our conversations, and we're looking forward to hearing from you. I'm going to pull up your slides as you introduce yourself further, but let me share your slides.
All right. Well, Lisa, you've been very thorough. I want to thank you all for this opportunity to talk to you. This, of course, November is National Hospice and Palliative Care Month, with the goal to increase awareness around the benefits of hospice and palliative care. Oftentimes, you hear the term advanced illness care, more the nomenclature used today. However, that is simply speaking of both hospice and palliative care. I'd like to start by asking how many persons have had hospice care for a loved one, perhaps by show of hand. Thank you. Well, I would first simply start, of course, with just an overview of what we'd like to talk about on the next slide, please. And let me simply start with some definitions around hospice and palliative care. Please, 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 let's have this to be very, very interactive. And you can certainly stop me or add anything. I would love that and welcome that. Next, I'd like to discuss some of the similarities and the differences between hospice and palliative care. A clear definition of the Medicare hospice benefit, I think, is important. Most persons will access the Medicare hospice benefit for their loved one, and then understanding options and the expectations should a loved one utilize hospice or palliative care. Most importantly, disparities in acceptance around hospice care among African American persons. And then I thought we could end with some myths, some misperceptions that are important to overcome. How does that sound? All right.
Great.
Okay, so we'll start with the definition of hospice care.
Okay, let me advance the slide. Hold tight.
Thank you so much.
There you go.
All right. So hospice, by definition, is really a team-oriented approach to providing a specialized plan of care for anyone facing a life-limiting, a serious illness. Oftentimes, the word terminal is avoided because that's going to create a greater sense of fear. So you often hear the term life-limiting, serious, advanced, progressive illness. The focus of hospice is, of course, on comfort care. And I'm sure many people have heard that terminology used. With hospice, the focus, again, is providing comfort, and there's thought to be no cure for that very serious, progressive illness that a loved one is experiencing. As Lisa mentioned, the care is holistic. It not only provides for the physical aspects of someone's suffering, but the spiritual and emotional piece are equally important. What's also important is allowing caregivers, allowing family members to be family members and not to have the whole responsibility of caregiving. So support is provided for the patient's loved ones and their families as well. I think that is so key in terms of the benefit of hospice. Now, palliative care is also a specialized medical treatment option that focuses on providing relief of pain and bothersome symptoms. So Palliative care can begin at any stage of an illness, whereas hospice typically is more designed for the end of life. And I'll share some more specifics around the hospice Medicare benefit shortly. But with palliative care, again, it can begin at any age, at any stage of someone's illness. Palliative care can be provided if the illness is curable, if it's chronic, or if it's life-limiting. And as Melody and many of you all know, oftentimes palliative care is a bridge to hospice care. Sometimes the recommendation for palliative care is a softer approach for someone who may actually be appropriate for hospice care or soon to be a candidate for palliative care. With palliative care, oftentimes your loved one can receive other treatments such as PT, OT, speech therapy, specialized nursing care. With hospice, typically additional therapies are not included. So a palliative care consult is just like seeing any other medical specialist. It's just like seeing an oncologist, a neurologist, or nephrologist. So both palliative care physicians, nurse practitioners, hospice doctors, hospice nurse practitioners have gone to have additional specialty training with focus on pain management, as Lisa mentioned, and alleviation or ease of bothersome symptoms, things like nausea, vomiting, anxiety, and a variety of other things. But the whole focus for both of these modalities is indeed comfort care. Just sharing, again, as I'll probably repeat myself a little bit here, but again, palliative care can start at any time during the illness. I've heard that palliative care can be recommended for pregnant women who have issues with nausea and vomiting. Their OB/GYN has tried a lot of modalities. It's not eased. Then they may actually be referred to a palliative care doctor to take care of this bothersome symptom. Palliative care can be utilized again at any age, They both share the same principles of pain and symptom management. And with palliative care, typically your loved one is going to be seen by either a palliative care doctor or a nurse practitioner, whereas with hospice, as many of you know, your loved one and the family, the caregiver, is afforded with a full complement of specially trained caregivers to include not only a hospice medical doctor, but a nurse, typically a registered nurse, sometimes an LPN, licensed practical nurse, a social worker, volunteers, as well as chaplains. The whole approach for hospice is kind of a team. It's interdisciplinary. Any questions so far? Or comments? All right. So I wanted to share with you, and this is directly from my organization. I think other organizations would have the same type of referral indicators, but generally, if your loved one is experiencing any of these concerns, 1, 2, 3, or all, it may be appropriate to be appropriate and ask about a palliative care consult, or if they're further down the trajectory with a very serious progressive illness, even seeking out, being proactive and seeking out a request for a hospice consult, which is generally provided by a nurse in any setting, whether that be a private home, assisted living, nursing home. Some hospitals will provide hospice care in-house as well. So
Betty,
I think, yes. Mm-hmm.
These significant symptoms, we may feel it's important. Who makes the determination Does the physician make the determination that it's palliative care or hospice care? If we are seeing some of these things, who makes that determination?
Lisa, ultimately, it has to be a clinician. It has to be a doctor or a nurse practitioner. Yet, as a part of our advocacy, I say anyone who recognizes these symptoms that your loved one may be experiencing, please, I encourage you to be proactive and seek out that primary care doctor, or if there's a specialist involved, and say, my loved one is experiencing these things. I'd like to consider a palliative care consult, or I'd like to consider hospice. Ultimately, though, a physician has to write an order to move forward. Does that answer your question?
Yes, thank you.
Certainly.
Next slide.
Please. All right. So we talked about hospice being a team approach to caring, and I just thought I would share briefly here those persons that are involved. Of course, there's a hospice medical doctor. Most of the time at the helm of hospice care, it's really going to be the nurse. The hospice doctor will oversee the plan of care, yet most often your loved one will be assessed by a nurse, typically a registered nurse, sometimes aided by a licensed practical nurse, an LPN. The visits typically are weekly. Hospice care, as you all know, those who've had the experience, is not custodial. So the hospice team is not there all the time, but they would make scheduled visits. They should make scheduled visits. There is a certified nurse's aide involved with the activities of daily living, that term ADLs, with bathing, dressing, oftentimes general, very light housekeeping around where your loved one resides. In other words, if they're in a hospital bed, making sure that area is neat and clean. The nurse's aides typically will visit anywhere from, I think the average is about 3 times a week, more visits if there's a steep decline. Also involved as a part of that team is going to be the social worker. Social worker's goal is simply to see if there are other resources in the community that may be of benefit, but then also to deal with that psychosocial piece of what may be going on. As many of you know, all pain is not physical. That pain may be something long-standing. So much pain is social or spiritual, and a social worker can help with those concerns as well. Chaplain. Most chaplains are going to be non-denominational, but they're also going to deal with the spiritual well-being of a loved one and provide support for the family also. A chaplain has reminded me to say that he can do more than just provide a prayer, but there to provide presence, to listen, to hold a hand. And again, being non-denominational, but addressing those spiritual needs that a loved one may have. Grief and bereavement counselors are part of that interdisciplinary team, as well as volunteers, believe it or not. How many of you know that volunteers are an essential part of hospice care? Yeah. As a matter of fact, the Medicare benefit requires that any hospice worth its salt would have a certain percentage. I believe it's 5% of the care needs to be provided by a volunteer. Yet, rest assured, that volunteer has to go through training. They should be vetted, background check, and medical tests, TB checks, things of that sort, vaccinations all in place before they can actually be involved in providing support to a patient. And then, as mentioned here, it's, I say that hospice is person-centered. That's the goal. It's really person-centered. And if there are any of these disciplines that your loved one says no to, or the family says no to, you do have options. Yet, per Medicare, the disciplines that you have to have be involved, of course, would be those providing medical care, being the hospice doctor or the hospice nurse. Does that make sense?
Mhm.
All right. We can move on. Go on.
Question.
Yes.
Looking at the typical 3 times per week. So a social worker, chaplain, or grief counselor or volunteers, you would not get more than 3 visits by either one of them per week.
Yes, and that's an excellent question. To be clear, at the beginning of care, the social worker is more involved, yet the social worker visits much less frequently in person. Oftentimes they are available by phone. The bulk of the care is going to really be provided by that CNA, the Angels of Hospice, the Certified Nurse's Aide, or the registered nurse. As your loved ones start to decline, the visits should become more frequent, yet I never want to overpromise. And typically, most nurses' aides are there about 3 times a week. The nurse visits weekly, the social worker and the chaplain less often. Melody, would you tend to agree with that range of time period? You're on mute.
Yeah. I agree. One thing that I wanted you to stress, Betty, is the myth that most people think that hospice is a place as opposed to it being a service. So if you could kind of speak about that, I think that would be helpful.
All right. Well, thank you. Yes, one of the myths that is mentioned is that many people think hospice is a place. Candidly, I thought that too before I began working with this organization 16 years ago. But hospice is provided a service, as Melanie said, wherever someone calls home, be it a private apartment, be it a townhouse, be it an estate, be it a car. I know in the case of the organization that I work for, we've cared for persons who are homeless and they live in their car. We have cared for someone under the bridge. So wherever that person considers to be his or her home is where our team is bound to provide the service however we can.
Wow.
Some hospices do have inpatient centers. I'll get into that a little bit later, being mindful of time. Yet hospice, as Melody said, is a service, and we provide that service wherever someone calls home. Now for the Medicare benefit, I smile when I say this. So Medicare Part A, as in Apple, covers hospice, covers the visits of this interdisciplinary team that I've mentioned at 100%. I've been advised never say 100%. And the reason is because we mentioned briefly, there's a specialized treatment plan or plan of care. And oftentimes, if loved ones or family members step outside of that care, they may receive a bill. However, I would say 99.5% of the time, hospice care Part A is covered at 100%. And again, that's the visits of the team, that's medical equipment that your loved one might benefit from. That's actually medications that your loved one needs based on whatever their diagnosis is. So typically, we used to say, and it's still true, hospice is really a best kept secret. I say, if someone's struggling to care for their loved one in their home and their loved one is experiencing those referral indicators that we referred to, 1, 2, 3, 4, 5, 6, 7, 8, or 9 of them, it's worth a discussion about this benefit. Our loved ones perhaps have worked for this, and it is, in a sense, it's an entitlement for this level of care. TRICARE covers hospice at about 100%, Medicaid as well, and palliative care, however, as I mentioned, it's just like going to see a specialty doctor. So it should be covered under, for example, Medicare Part D or private insurance. Private insurance, the Aetnas, the Blue Cross Blue Shields, the Care First will cover hospice as well. Yet there's typically, sometimes there's a copay. And in any hospice organization that you deal with should have financial specialists that can suss out what the benefits are. But most importantly, too, I wanted to share with you that for hospice, and Lisa alluded to this earlier, a clinician, doctor, a nurse practitioner has to certify. In other words, they've got to sign their name on a certification of illness that they believe your loved one would perhaps die within 6 months or less if that disease, whatever it is, heart disease, dementia, end-stage kidney disease, if that disease follows a downward trajectory. So that is a stated qualification of the hospice benefit. Now, good news is that this is not under our control. And as loved ones live beyond the 6-month time period, there's simply a recertification of illness. And that's done usually by the hospice doctor at that point.
Mm-hmm.
Hey, Betty,
Yes.
can I, well, you can, it's been a while for me to clarify on this, but one way to kind of remember is Part A is usually the hospital benefit. That's what a hospice is covered under, Part A. And then also, Betty just mentioned about the certification. One thing to keep in mind that it takes 2 people, clinicians, to certify a patient as being hospice appropriate under the Medicare guidelines.
Absolutely. And that second person typically is going to be the hospice doctor. Now, typically, if a specialist, oncologist, neurologist recommends hospice care, I would say probably, what would you say, Melody? Probably 95% of the time, there's not going to be any pushback. However, the hospice doctor has to also agree that that person is, as we use the term, medically appropriate for this level of care, for this treatment option. Now, oftentimes there can be a review if there is a disagreement, but again, 2 physicians have to agree that this level of care is appropriate.
But Linda has a question.
Oh, sure.
Yes, hi.
Hi.
A lot of times, and for a lot of us, the medical system can be a little difficult to maneuver. Where would you suggest is the starting point if you need to seek hospice care?
Well, thank you. That's a great question. I would suggest, depending on the illness, the serious progressive advanced illness that your loved one is having, I would suggest starting perhaps with the primary care doctor, or if there's a specialist, simply have a candid conversation. Also, online offers some resources of a list of questions that you can utilize to ask your primary care doctor, and ask them if they would make a referral, and all they have to do is simply say, I refer Mrs. X, Mr. P for a hospice or palliative care consult. They fax it into a company of choice, and from that point, a nurse can start the process to make the initial assessment to make sure that that person is medically appropriate for care, either palliative care or hospice. Oftentimes, clinicians are more comfortable making a palliative care consult initially, and that can also be a bridge later down the pike for hospice care. I hope that helps.
Yes, thank you.
Oh, certainly.
Hey, Betty, can I chime in?
Oh, please.
So from a practical standpoint, when I say boots on the ground, if you have a loved one that is consistently going in and out of the hospital, and you're having to go to take them to the doctor, and it's just one episode after another, etc., that might be an indicator for you to have the discussion about palliative care first, and then having the physician to go down that road with you, because they have their own parameters that they look for. And if it should take the winding road towards hospice, they would definitely know how to get you there. So
Yeah.
based on just, start keeping a calendar or whatever you need to keep, but you'll know, because you'll get tired of having to run back and forth with that individual, for lack of a better way of saying it.
Yeah, that's an excellent point. That's very excellent. Thank you. All right, let's see. At this point then, understanding expectations. Wow. When your loved one gets into one of these programs, as we all know, we've got to be advocates for our loved ones' best care. So no matter whether it's a heart disease, lung disease, dementia, or cancer, you've got to advocate for the best on the part of that hospice team. I always say that if, for example, you are assigned a nurse and that nurse is not a good fit, call the hospice organization and ask for another person. It is your right to do so. The expectation should really be an enhanced, a better quality of life for your loved one, and support for the family, with the focus being on comfort care with hospice, not curative, but comfort care. Some hospices provide a bit more leniency, and they will allow perhaps a short stint of dialysis. They may provide some palliative radiation for cancer patients, but typically these things are more on a short-term basis, and a goals of care discussion would be important to make a determination as to whether additional therapies are more beneficial or whether they're providing an added burden to your loved one. So, the palliative care can be provided over a period of weeks or months or even years. Palliative care can work alongside, as we mentioned earlier, things like OT, PT, speech therapy, things of that sort. However, generally with hospice, there's not going to be allowed a lot of additional therapies. So advocate for your loved one, whether they're in a hospice program or a palliative care program. The expectation should be expert pain and symptom management and control as much as possible of bothersome symptoms that your loved one may be experiencing: nausea, shortness of breath, anxiety, delirium, for example, in dementia patients. All right. And then I wanted to share quickly here from the National Hospice and Palliative Care location, which of course is right here in Alexandria, but of persons who died, decedents. 35.5% were Black, and you can see about 50% were white, Asian 36%, and American Indian 33%, Hispanic 3%. Now, this is of persons who utilized the care and died. These are how the percentages go. Yet, for persons, what we call the death service ratio, which is really key. I apologize, I didn't get a slide for this. I just got this information later today. But for the availability of care and the utilization of care for what's called the death service ratio, 82% of Caucasian people utilize the hospice benefit. About 8% of African Americans utilize the hospice benefit. About 6% of the Hispanic population utilize the hospice benefit, and about 2% of Asian Americans. And that probably comes to about 98% then again, the other 2% would be members of other races, Alaskan, Pacific Islander, things of that sort. But you can see here, wow, 8% of persons in the Black community that perhaps were medically eligible and could utilize this service. It was a mere 8.2%. And again, that's when we get into talking about what Lisa mentioned earlier, the disparities, the barriers that prevent a service that's there and available from being utilized by people of color. All right. Can we go to the next slide if there are any questions? And then again, just looking at perhaps some of the reasons around these disparities. Oh, they're numerous. I don't know the answers. I want you all to kind of help me in my role in terms of how we can overcome some of these things. I see Belinda has a question too, I believe.
Yeah, and you've been mentioning what Medicare offers. Is the same service available to a person who may be Medicaid versus Medicare?
Yes. Medicaid also follows the Medicare benefit at 100%. In facilities, often Medicaid is utilized to pay for room and board too. And as we know, typically Medicaid is provided on an income basis for persons who perhaps who are less resourced. But Medicaid does have a hospice benefit as well, covering the services at nearly 100%. So many of the reasons for disparities around African American acceptance of hospice and or palliative care, oftentimes it's the physician to patient relationship. The doctor is not forthcoming in saying this is a viable option. It's asking, have you considered the benefits of palliative care or hospice for your loved one? It makes it more difficult for a potential recipient if that doctor is not more forthcoming in their discussions, saying your loved one has a very serious illness, they perhaps have a limited life expectancy, and having that discussion. Oftentimes that has to do with, as we say, the oath that physicians take. They feel that they can cure. We know at some point, though, in some conditions, there's certainly not a cure. And I think that those candid conversations sometimes are missing based on the physician-patient relationship. One study talks about health literacy, and it suggests that health literacy, as opposed to race and education, make it difficult for persons to accept hospice or palliative care. I certainly feel race is a major issue, but there's a study from the National Journal of Palliative Medicine that suggests it's actually a lack of knowledge and not as much race that causes this disparity. Of course, mistrust of the healthcare system. Oh Lord, we can go back and talk about the Tuskegee experiments, the syphilis experiments, and things of that sort. I get it. Many people are just not comfortable. There's that lack of trust. And then also lack of access to basic health care. In the work that I do, we run across still a significant number of persons that don't have a primary care doctor. Persons who are have no insurance or those who are underinsured. So that lack of access can certainly be a barrier to knowing about these two viable services for anyone with a serious progressive illness. And in talking to others, oftentimes, let's see, 1, 2, 3. Number 5 here, spiritual beliefs. By show of hands, have you heard a loved one or family member say, "This is my season. The Lord's not going to put any more on me than I can bear"? And this is a strongly held belief that sometimes can be very hard to overcome even though you're offering a service that might provide some support not only to that loved one, but to the family as well. A firm belief that aggressive treatments and life-preserving measures are always the best. Do all you can for my mom. Do all you can for my dad. Do all you can for my aunt. I get it. I understand it. And then, of course, I think Lisa alluded to this earlier, advanced care planning, things of that sort are sometimes not in place. And that can always be an avenue to knowing what your loved one wants and moving forward with that when there is a nearing end of life with a very serious progressive illness. So I think based on the time, let me one other thing here, just a few common myths that you may see, that you may hear. Melanie alluded to this. Many people think hospice is a place, and it's not. It's a service. As we mentioned, admission to hospice automatically means death. Oh, they put Mrs. Jones in hospice, and 3 or 4 weeks later she died. Number 3 is a myth that we hear oftentimes, that morphine is going to be administered and it's going to kill my loved one. A hospice social worker is going to come to my house and she wants to know about mom's money. She wants to know about dad's bank account. These are myths. And then the last one, though, is something that can be heartfelt among families. My brothers and sisters are going to be upset at me if I, as the POA, as the primary point of contact, if I sign up my mom or my dad for hospice, they're going to think that I'm giving up hope if I choose hospice. Can you all think of any other myths that you've heard of that might be barriers?
I know a lot of people are just confused, and a lot of times think palliative care is hospice as well. So they won't ask about it at all. But I would also like to state that the strong spiritual held beliefs in our community actually hold our community back, right? And I've noticed that a lot of people just really don't take an interest in their illness. And it says in the Bible that our people will perish for the lack of knowledge. And so a lot of times we hurt ourselves by not taking an interest in our illness to learn these things. And the lack of trust and all of that plays into it. But I think if we all became a little more knowledgeable about what we were going through, that could help some. Of course, lack of access as well is an issue.
Very well stated, Nicole. Yeah, thank you. Yeah, it's a battle. It really is. Studies also suggest that the lack of persons of color in this business, in this industry, is a barrier too. And I'll just briefly mention, with our organization, we've had to have a come to Jesus, if you will, discussion around a lot of the brochures, that the marketing materials. We have fought that they've got to be more inclusive. They've got to show a face, like I see here, of Stephanie, of Lisa, of Deborah, of the Reverend Wadi family. In other words, it's got to be more open and more welcoming, so that you won't hesitate perhaps to pick up a brochure at your doctor's office and learn more and educate yourself around it. The other thing too is these medical schools need to do a better job of understanding the totality of cultural beliefs, and do a better job of having that basic conversation when it's appropriate for your loved one to consider palliative or hospice care.
I think sometimes, can you hear me?
Yes,
Yes.
sir.
Okay, I think sometimes for us as a Black community, there's a cultural barrier that's there that suggests that if mom or dad is sick, I have to do it. I have to take care of them because they took care of me, and and we feel like we gotta kind of keep it in house. Um, and for whatever reasons, we feel like we got to keep it in house. And I think sometimes we think if we invite anybody else into it, you kind of mentioned it when they were talking about asking about mommy or dad's finances and all. We feel like we're going to give up some privacy. This, and I'm not sure why we have that idea, but we're giving up some kind of privacy. We're giving up something if we let these other services in. And I think sometimes doctors who well, for example, Janice's father was in the hospital, and they were getting ready to release him, but nobody had a car, but he was in a condition that was going to require more than what we could really do, but nobody ever mentioned that there were some other resources that could kind of help us. And in that moment, we were sort of facing, wow, what are we going to do? I mean, they're getting ready to, in a couple of hours, we got to put him in the car and take him home. But if we bring him home, it's really not going to help him. It's not really going to give him the quality. The thing that helped us, and I really do believe God sent this woman who happened to be there. She was getting ready to leave work, a social worker, getting ready to leave work. Whatever that she heard the conversation, and she stopped and she took the time to help us with some things to make it to where we needed to get him the proper care. But a lot of times, I think we feel like our loved ones, when they're sick and they're being discharged, because hospitals don't seem to want you there very long, that they're kind of being thrust on us now, and we got to do something, and we really don't know what to do. So I think it's really important that we talk about this issue and that we really do get these educational pieces out there so folks can really understand what it means. And you're right, hospice doesn't mean you're going to be dead next tomorrow.
Right.
But we get that idea for some reason okay, we got him there and we just go sit around for the next 2 days and wait. But I've known people been in hospice for a long time.
Yes, sir. Yes,
So,
To your point, Reverend Waddy and Nicole, even, my mother has been in hospice at home 5 times. And the comfort is the relief of the care that is given to the caregivers that are there. Her decline comes, she bounces back, she is recertified, she's let go, she can be recertified that you described, but it's a gift to the family to be able to do that. And may we have your slides to post on the site, Betty?
Oh, yes, ma'am. Absolutely. Yeah.
Thank you.
This just kind of touches the surface. There's so many other avenues,
Yeah.
as you
And
all
will you come
know.
back? Will you come back now that we know you've mentioned for us education, awareness? You all have heard this. If you have additional questions, we want you to feel comfortable to ask these questions. You're just scratching the surface with Betty, with Gigi, with Melody, both of them who are key. But you now have a point of contact. If you have questions, you can ask these questions. And if your friend and that other friend has a question, you have somebody that can answer some questions for us. That's part of why we do this.
I would also like to ask permission to write an article on this topic using your resources, if possible. I am a guest blogger for WebMD for sickle cell disease. And I also I sit on the board for the Pulmonary Hypertension Association as well. And I think this is good info because we have we've had a struggle with this conversation for many years with people with PH. It is a progressive chronic illness.
Mhm.
And people are confused and afraid. And I would just like to do my part as well. I am also a certified death doula. So sometimes people look at me and they don't want to see me coming. But, but
Tell people on the call what that is, Nicole. Not everybody will understand that.
so I'm an end of life companion, basically. And actually, I do a lot of volunteer work, and my next volunteer project is going to be volunteering for hospice work. But as an end of life companion, I can do anything. I can help plan legacy projects. I can sit vigil with family. I can help practice any spiritual practices or any ritualistic things that the family would like to do to honor their loved one. I do a lot of different things. So yeah.
That's amazing.
Yes, you
We're
do, Nicole.
we're moving away from traditional funerals and that kind of thing. So I think, the end of life companion is the proper term, but people are moving more towards doula services than they have in the past. And we have such a stigma about death in this country. I think that that's also something to help broaden the conversation and the spectrum of death as not something to be afraid of, but to look forward to in some instances.
Mhm.
But with your permission, I would love to use your information to write an article if that's okay.
Yes, Nicole, it is. If I can help in any way, if I can give you some sources for your footnotes, I'm happy to do that as well.
Wonderful.
Lisa and Jabs, they have my information.
Thank
Yeah.
you.
Okay.
Melody?
Yes, so I want to help, and you all forgive me, this machine's going in the background, but I have to do some work. But anyway, what I was going to say, I was listening to Reverend Waddy. One of the things that I think, Lisa, that you might want to look into is having someone to come from the Area Agency on Aging, because the Area Agency on Aging can help a lot of the churches and different organizations help families bridge that gap from when that person is transitioning from a hospital to transitioning to home or wherever. You want it to be a safe transition, but the Area of Agency on Aging can give you the resources that are out there and how to access those resources. And one last point that I'm going to mention is that with hospice, and Betty will get in here and clean it up if I say it wrong, they also provide, as part of the hospice service, respite care. And I'll let Betty explain it, and I'm going to keep quiet.
Oh, well, yes, thank you. Yes, the benefit, as I said, we're just, and I thank you all for this opportunity to share, touching the surface, but a hospice worth of salt should be able to provide 4 levels of care. And one of those is indeed respite care, which allows for caregiver break or caregiver relief. I'm not sure, Lisa, if you've had a chance, if you have ever needed to utilize this, but typically it's about 5 days, and you can have your loved one go to a certified facility for a period of time so that you, the caregiver, can have a respite, a rest, or a break. That can be at a hospice inpatient center or at a certified facility, typically a nursing home. Some assisted livings provide that as well. However, let's say if your loved one has a very serious illness, their acuity level is high, then you would probably want to have that respite at a nursing facility or a hospice inpatient center.
And I promise,
right?
I promise I wasn't gonna say much after this, but I want to give you a scenario that can take place. And this was an actual truth. I had some friends that were in Virginia, and they were doing the bulk of the care for the mother. And then there was a brother down in South Carolina. So the hospice did a transfer to transfer. And so the mother was able to go to South Carolina, and the hospice services picked right up and gave the the daughter a break in Virginia and the brother cared for it. So I know some of you get into those sibling scenarios. So I just wanted you to have that food for thought.
Guilt. Guilt.
No,
There's-
no guilt, Nicole. So jokingly, a couple of things, and I'm mindful of y'all's time. I want to respect it. So we always say, this is not your grandmother's hospice anymore. And then hospice has a travel benefit, as Melody alluded to. We get persons coming into the DMV from other areas, and they sign on with our hospice for the time that their loved one is here. The benefit never ends, as Lisa's dear mom, God bless her, knows. Recertification after a period of time, but you can go in and out of hospice care, and the good Lord graduates some people from hospice, as y'all know.
I appreciate those comments, because the respite care is one that we have not used. I'm going to ask a financial question around that. Is respite paid for?
The answer is yes. However, it's for a limited period of time.
Okay.
It is usually
Okay.
about 5 days, but that's a part of the benefit too.
Now, this is a medical question for those whose loved ones have dementia or Alzheimer's. Transferring them from another environment is a concern. That is, so I'm hesitant to do something like that. I use multiple caregivers to give my sister-in-law a break, but we're fortunate that way. For those who can't do that, is there a recommendation for someone who needs that? And how do you manage? Who do we talk to, if not you, on how to manage a loved one who can't be removed from the home?
Needing respite care?
Yes.
You're saying? Well, I would say you'd want to speak with generally the hospice nurse and the hospice doctor if they're already in the program, and they can approve that level of care for either caregiver break. Oftentimes the people will say, well, we need to go to my niece's graduation and mom can't travel. So that's an example, but the hospice doctor, the hospice nurse can arrange that.
But I'm asking transferring the patient themselves, because it'll disrupt them. I would not be able to I'd be stressed. I couldn't rest.
Yeah.
So here's go ahead.
I think oftentimes it's case by case.
Okay.
If I'm understanding you correctly, because sometimes families will transfer by car if the acuity level is higher and there needs to be, let's say, an ambulance, then that may be something out of pocket. I think it's case by case. It's kind of hard for me to answer that. Melody, you have any thoughts on it?
Yes, so here's what I was going to say. You can also use non-medical transport. And then, like Betty says, some of the places like assisted living facilities that actually have the memory care units, believe it or not, a lot of these assisted living facility places, actually, they have vans, and they could actually transport that patient over to that facility. If they're not able to walk, then you can do the non-medical transport. Those are not that expensive to do at all. And sometimes they even have, if you talk with the medical transport people, they have a different rate for scenarios in that case. So the options are out there. The biggest thing is you have to be comfortable. If you have a patient that's bedridden and they're having to use the Hoyer lift, etc., you just want to make sure that that facility, as it relates to an assisted living facility, having those same sort of equipment, technology accessible to them. A nursing home indelibly is going to have that, but an assisted living may not be able to provide that level of care.
It's good to
Well,
know.
those are good. That's great information. It's 7:30. I'm not going to cut you off. If those of you who want to leave, we're still recording. If Betty, if you want to stay. I'm not going to cut you off. So, Nicole?
I just have one last question. Could you give us some information on how long after hospice the grief and bereavement portion of that service is available?
Oh, yes, Nicole. So typically, after your loved one dies or goes on, transitions to glory, the grief and bereavement counselor should be in touch with the loved one, because again, not only is the service patient-centered, but family-centered too. They should be contacting you for 13 months. And the reason is to make sure that contact covers the 1 year anniversary of the loss of your loved one. And oftentimes some hospice entities will make phone calls, and they also do mailings. They also should offer support groups, and they can be individual or they can be group sessions, whatever you can opt for that you're most comfortable with. One-on-one telephone calls, group sessions, things of that sort.
Right.
It's 13 months period of time.
Thank you.
And for nonprofit organizations, it's not a requirement that your loved one was a part of that hospice to utilize these services, because they should be nonprofit, community-based. And if you have a need, a sadness, a loneliness, and you feel like you could benefit, you should simply contact one of these agencies, one of these entities, to take advantage of these services.
Wonderful. Thank you.
Sure.
You don't have to be quiet. We're here as long as you want to be here. So,
That was all I had.
okay.
Thank you for
I have
the
a
work and the care that you do, Nicole. It's so important.
Thank you too. Thank you.
Now, by show of hands, I didn't mean to interrupt. How many of you are caregivers for family members or loved ones currently? I know that Lisa is. Okay. Well, thank you. I'm just gonna give you a heart.
Very important.
Thank you.
Some of us have already done that.
Yes, you
Bless you,
have.
bless you, bless you, bless you. Yes.
Yeah.
I have a question,
Who's the question from?
Marguerite.
Hey, Marguerite.
Hey, how you doing?
Okay.
Listen, I've been hearing that hospice is for a life ending. How do you say it?
Well, we usually say life limiting, a serious progressive illness, end of life, terminal, even.
Yeah, end of life, terminal. But
Yes,
that's
ma'am.
not always the case. Because I've known some people who have been in hospice and they've overcome it.
Oh, yes,
And
ma'am.
they are, productive individuals now. So
Yeah.
do you have to say it is or it could be?
Yes, the benefit, the Medicare benefit suggests, and the verbiage goes something like this. Two physicians have to certify that they would not be surprised if your loved one did die within 6 months if the disease followed a normal course, a downward trajectory. However, if your loved one does not die, then the benefit can continue. And it's semantics, it's terminology. However, most times they're certifying that this is a very serious illness, and your loved one is there's thought to be no cure around it. I hope that helps. But I mean, to your point, yeah, some people have graduated, and that's the celebration.
Oh, yes.
And also, keep in mind that all physicians are not trained in end of life scenarios. That's why you have a lot of the palliative care and hospice physicians. They are actively going around and training the physicians on that, because that's not what they were trained to do. And don't be surprised when you might run into maybe like an oncologist that does not believe in hospice care at all.
Mhm.
They will treat till they can't treat anymore and put you on any clinical trial that's that they could think could be remotely helpful to you, you know, under the circumstances. I'm not saying that there's anything wrong with that. I'm just giving you food for knowledge or food for thought.
There comes a time when sometimes we have to advocate for our family members or loved ones and just say enough is enough and we need another option, you know.
Mm-hmm.
Another term you all will hear is benefit versus burden. Benefit versus burden.
Okay. Well, I thank you all for joining. For those of you, look out for the survey. We'll have the replay posted soon. Japs, thank you for all that you do. She will be sending out resources. We will take this resource. It will be sent out to those of you who were on the call. It will be posted on the BAAHRI website, all of those places. Give us 48 hours. Japs will probably have it done in less than that, but I give her 48 hours to have things done. We thank you. Next month, we'll have Dr. Jane Middlebrooks, and Jane is the stairwell physician. She'll talk about COVID, and she'll talk about vaccines and pneumonia. Tell your friends, share your information. I'm sure it'll be a treat. I will be in the Riviera Maya, doing that one. I am going to travel. It'll be my first trip with this surgery, with this knee, but I've been cleared to travel and to do it. So I'm looking forward to that. Japs, I'll need you on standby in the background for that one, for sure.
Jealous.
Don't be jealous. I'll take you next time, Nicole. You want to come? Let's go. You
well deserved.
Yeah, thank you.
Deserve it.
Oh, thank you. I appreciate each and every one of the family, you know, our collective family, for being on the call. Betty, we can't thank you enough for your information, your sharing of your expertise, and your compassion for what you do. Gigi, thank you. Well, Melody, I say Gigi, thank you for your support and your reference of sharing Betty with us. We appreciate that. And everybody, I'm going to stop the recording. And if you have anything else that you'd like to share or say, then we will be on the line.